Thank you for tuning into Kineticast. Today we have Dr. Nick Askey joining me, and we're going to be talking about great toe extension, different functional changes that happen when there's a limit to the extension, and then we're going to go into some different functional patterns and just kind of spitball some stuff because Dr. Askey is someone that I actually knew before I became a doc, and he's actually helped me with a lot of my rehab, and I've learned a lot from him, so I wanted to bring him on so we could all share in his knowledge. Doc, thanks for joining us today.
You bet, man. I'm still suffering from a little bit of hangover depression from the Badgers basketball loss yesterday, and I think it's a bit of a stretch to call it a loss. It was a throttling.
Yeah, I think that was the first thing I said to you when I got here because I walked in, and I know you're a big Wisconsin fan, and I walked in and I said, what happened? Because I didn't even watch that game because I just assumed with the history, with the team, I mean, you were going to just go to the next round. I have it in my bracket. Oh, any bracket I filled out had them going.
Yeah, I had them upsetting the 4 seed the next round too, so my bracket is done between them and Marquette.
Yeah, Marquette.
Marquette pooped the bed for sure.
Man, and then what was it? Iowa State too lost, didn't they?
I think so.
Yeah.
And another 4 seed went down.
A bunch of them.
Yeah.
Not as much as last year though, because that's what I was.
You had the 16-1 upset last year,
yeah.
And that wasn't that was a blowout.
Yeah, Liberty just won. That's what it was, right? Liberty just beat somebody. Mississippi State, was it?
Yeah, I think so.
Yeah. So now it was. I mean, besides NCAA, we could probably go for hours on that.
Yeah.
Let's jump into some movement.
Absolutely.
So, what do you see? Okay, I know great toe extension is something that I think is missed a lot by a lot of practitioners, and I think it's because there's a lack of knowledge of it. I think there's a lack of being able to assess it, what you're looking for, and the changes that you can see in the body from it too. So, let's go ahead and have you start this going on. What you think you look at for it?
So, people that have listened to me talk and lecture since like 2012 probably think I have some sort of like big toe foot fetish because I'm going to look at the big toe first and foremost for most lower extremity stuff, and if my screen is negative for things all the way up to the low back or TL junction, I'm going to look down at the big toe. I look at it first for plantar fasciitis. I look at it and the assessment piece is key because a lot of people, they'll just pull the big toe into extension and they won't anchor that MTP joint to where that ground is putting some force up through that, and if you don't mimic that ground reaction force and then isolate the extension through the big toe, you're going to get a false clear result because you can pull on a fused bunion and pull it into 30 degrees of extension and you'd be like, oh, that's normal, but the joint is actually fused. You're just blowing through the medial arch.
You can push passive range of motion farther than you can push anything else. And that's not what anybody's doing when they're active. They're not passively going through range of motion. They're active.
Yeah.
So I think that's the issue there.
And if you have to look at the way that people will compensate around a stiff big toe. And there's 2 ways that a stiff big toe will kind of form. And it's almost, I explain it to people almost like the 2 different kinds of atrophy. Like you have disuse atrophy and then you have a neurologic atrophy. So in a stiff big toe, you're going to have someone who is either a habitual supinator to where they never really get to toe off because they're stuck in that supinated state and they don't have the strength with their peroneus longus to pull that first ray into the ground. So they're really toeing off of their second toe. Right. They may have a Morton's foot to where the second toe has more mechanical advantage because it's longer and they're toeing off of the second toe. So that's the first kind of stiffness, is they just don't use it because of a biomechanical problem or a foot structure issue with like a stiff, rigid pes cavus foot. Yeah. The second kind of type is something that it may be like a chronically untreated turf toe, or someone goes and gets a bunion surgery and that toe is inherently stiff, so they just avoid it. So it's one of those chicken or the egg kind of things. Like, does the person avoid toe off and propulsion from the big toe because it hurt, or it hurt in the past and that's their new normal? Or are they avoiding it just because they have a biomechanical and structural foot type that just lends themselves to not getting that first ray to the ground in the gait cycle.
And is that coming from more of your history and then your gait analysis whenever they're going through, or how are you getting to that?
History, the gait analysis will look similar. Like those will look the same.
Yeah.
You can sometimes tell by looking at like corns on the feet or calluses. Like if they have hammer toes to where they're really gripping, you know that was a long-standing problem. But the history is going to tell you if they had a bunion surgery, or they had a history of turf toe or sesamoiditis, to where they have a painful, just kind of a fear avoidance behavior of toeing off of that big toe. And sometimes just our footwear is going to encourage that, because it's hard for you to get big toe range of motion, or if you're stiff and you wear a high heel, that's almost like hip flexion in someone with an anterior tilt of the pelvis. They're already starting out in more hip flexion.
Right.
If you have a huge heel lift, you're already starting out in maybe end range big toe extension, and you're just going to form bone spurs on the top of the foot, or it's just going to make you more symptomatic the more elevated your heel is.
Yeah, I mean, when you talk about the high heels, I mean, besides like the high heels you wear on Saturday nights or anything like that, but you're talking about the people going out and wearing like stilettos and stuff, right?
Yeah.
Like they're wearing these 6-inch heels, and then they're going to try to walk, and usually you're not just walking from the car to the restaurant and back. You're going to go walk around, you're doing stuff, being active.
Yeah.
And then you're locking that great toe in, and then you're gonna wonder why I'm having this pain up the chain, right?
Yeah.
And that's I'm sure you see that all the time with patients.
Yeah. I was thinking about that this morning because I knew that we were going to be talking about this. If you look at the way someone will compensate around a stiff and or painful big toe, it's no wonder why medial meniscus degenerative tears are so common, because people are either going to stay on the outside of their foot, or they're going to toe off, and they're going to kind of roll that toe and create that deformity, that angular deformity, that hallux valgus. And if you put a rotational valgus trauma through that medial meniscus over and over again because you're avoiding a big toe that will extend, there's only a matter of time before you get a peripheral degenerative tear just from, like, you're not using the knee as a hinge joint, you're just stressing that ginglymus portion of the knee joint to the max.
Yeah, for sure. I mean, and again, then you take tissues that aren't supposed to move a certain way, or supposed to, like, the knee is supposed to have some transverse plane movement, not a lot, but just a little bit. But whenever I talk a lot, well, this with Dr. Camo a lot, like whenever you're losing range of motion in joints below or above, that knee is usually trying to take that range of motion and make up for it.
Yeah.
And then you're talking about medial meniscus. And any of my listeners probably have heard me say this about 1,000 times because I have a medial meniscus tear.
Yeah.
And like you look at my great toe, it does go valgus. And I wonder if just from basketball, weightlifting, all that, that's where it came from. But
yeah,
I mean, you don't know, chicken or the egg, right? That's what you're saying?
And you have a recipe for disaster when you have triplanar joints that surround a hinge joint.
Yes, exactly.
Like, the elbow is a bit different because you have more degrees of freedom and you have more mobility because it's a rotational and a hinge joint, more than the 8 to 12 degrees that you get out of the knee.
Plus not weight bearing too.
Yeah.
Yeah.
Unless you're doing 19.4.
Yeah, it's definitely weight bearing.
Yeah.
Was that the thrusters and the?
No, that was the handstand.
Oh, that's
walk,
right. Yeah.
Handstand
but you went straight to thrusters right after that, didn't you?
Yeah.
Yeah. So it doesn't matter. You're always going to be weighted there anyway. Yeah. So CrossFit, you're pretty much, your elbows are weighted. I take that back.
Yep.
So now we're talking about great toe moving up to the knee. Now, the one big thing that I think a lot of people miss too is how the foot can actually affect into the hips, the spine, and above. So whenever you start to assess somebody and you're looking at somebody that maybe has a back pain or a hip or maybe even going up a little higher, how do you take it down to say, hey, I'm going to look at the great toe. Like, this is somewhere I need to go, compared to being like, okay, well, maybe this is like a glute med or it's something up there.
So Thomas Myers has a very powerful quote that you have to look globally, examine locally, and then zoom back out again and act globally.
Yep.
So I have to go, okay, like the kinetic chain works like you're throwing a stone into a pond and then the ripples spread out from there. So I'm going to start at the symptomatic area, just to make sure that I'm not making this trickier than it has to be.
Right.
Because it takes a decent amount of communication ability to communicate that the person's pain is coming from their toe when it's really in their back.
Right.
It's a lot simpler to clear out those local tissues if there is a local problem, because that's low-hanging fruit. That's basically like, okay, if you have a ton of deficits proximally, we want to address those before we just go chasing distally.
Right.
But I look at the architecture of the kind of the tibial torsion piece first.
Yep.
Because a lot of people, they'll have glute med, posterior capsule, SI joint issues just because they've been cued to walk with their feet straight or squat with their feet straight, and they have a huge amount of external tibial torsion. So they're basically impinging the front of their hip because they're walking around in a fadere, like internal rotation. Like it'd be pigeon-toed for someone with normal morphology in their tibia.
Yeah.
So I look there first. If somebody has a chronic history of big toe stiffness, it's going to be like a baby Bunyan Rudolph red, like staring at you right in the face. And if you're a practitioner, you should make a habit of looking at people's feet, not just like not having them take their socks off. Because being in San Antonio, a third of this town is diabetic, and someone could have a sore or a wound on their foot that they don't know about, and that could get pretty rowdy if they don't know about it and they're diabetic, and that thing isn't healing. It's getting infected, gangrenous. You could set off a Charcot joint, osteomyelitis, like all these other gnarly things. Yeah. So just have your patients take their socks off, because then you can see their callus formation. You can see if they have corns on the top knuckles of the toes just from friction rubbing. You can see where they're toeing off. That's almost like looking at wear patterns on shoes. They don't lie. They're just going to develop a callus formation. So I'm looking at the big toe extension, and if it is dramatically reduced asymmetrically, like that's going to predispose someone to injury more than if they're just symmetrically stiff.
Right.
Like if they're symmetrically stiff, they're just not efficient, but they're not at as high of a risk of injury as if you have 5 degrees of extension on one side and 35 degrees of extension on the other.
And I completely agree. And there's a lot out right now about asymmetries not being a huge deal. And I think that asymmetries, no matter what, are going to play a part into your movement and your biomechanics. So you can't just ignore asymmetry because people say that asymmetries don't matter. Asymmetries do matter. Like you just said, 5 degrees compared to 35 degrees on one side, that's going to change how you walk, how you move. I mean, especially if you're doing a CrossFitter. Think about all the things you have to do. Box jumps, lunges, all that stuff that you're going to be moving, and you're pushing off that great toe. One side works, one side doesn't.
Yeah. You can't just go, okay, the big toe problem's on this side, so it's going to march straight up that ipsilateral side, because like what you said, if they have an aversion to jumping or landing on that side, like they're going to go to the other side, overload it, and it's going to move the problem to the other side, because there's no one-size-fits-all rubric for left big toe is going to go to the right hip.
Right.
It just doesn't work that way, because otherwise AI would have our job by now.
Yep.
Like, you have to look at it and be a critical thinker and go, okay, am I trying to make everything a big toe, or is this legitimately a big toe? I'll look at people walk too, and they'll almost have a Trendelenburg on that same side, because they're going to want to stay on their lateral foot as long as possible. Okay. A lot of times they will hyperextend their knee, and you'll get like distal hamstring complaints or popliteus complaints, just because they're trying to get as long of a stride as possible with a lack of propulsion off of that big toe. So they're going to stay on the outside of their foot, so you're going to get a weight shift. A lot of times that arm on the same side will shift across midline, because they're trying to shift as much weight to keep them from falling over to that side. Yeah. So you'll see an arm swing across midline a lot of times on the same side of the stiff big toe. And if you eccentrically stretch a glute med every time you take a step, like that may induce a tendinopathy or a trochanteric bursitis, retrotrochanteric pain. If you're toeing out, you're going to take the mechanical advantage away from the piriformis to stabilize the anterior side of the SI joint. So you could have some SI joint issues. You're going to have to take an asymmetrically longer stride on the opposite side. So you're going to have asymmetric stride length, maybe a little bit more anterior tilt on the other side. So it really can jump up the chain.
Yeah, and boom, there you go. There's a great toe extension into low back pain right there.
Yeah.
So you said a couple things that I'm going to see if I can get all of them.
Yeah.
There's some things I want to jump back into what you said.
Absolutely.
First is San Antonio. I don't blame anybody because I love tortillas and there's just, quesadillas everywhere. You've got some of the best Mexican food down here. That's going to be generally feeding into your diabetes.
Yep.
So, can't hate on them for that.
Nope.
Secondly, you talked about just take the socks off. Look at the feet. There was a classmate of mine, now Dr. Michael Hauk. He was one of the first ones to ever say that to me. Just going through, I think we were just try 3s or 4s, and he said, "Beau, whenever you look at people, what are you doing?" And I just kind of told him. He goes, "Well, make sure you always take their socks off." And I was like, "That's a really good point, Mike." And we just thought about that, and that's what I started doing people as an intern even.
Yeah.
It's taking their shoes off. You can actually visually see what's changing in their body to try to compensate for how their walking pattern.
Yeah.
Right? I think that was a really, really good point.
Yeah.
Now, AI. So I work with KinetiSense, so I've got the functional movement screening, all that. The new functional planar mapping tool that we have, I screened someone through the whole CAMS movement assessment, and they had a left sprained ankle. And it actually showed the stability compensation pattern for how the knee needed stability, the left glute needed stability, and went up to the right shoulder. So super cool. I was able to follow that pathway. But then you think, like you said, AI is not going to take our job, and that is a great point. This is just an assessment tool.
Yes.
What does the doctor do with that? And that's whenever the doc needs to be able to have this information and be able to use that information in treatment.
Yeah, it's just like interpreting an MRI.
Right.
Like the trap that we fall into is technology allows us to gather so much data that it's overwhelming. It's up to you to put your thinking cap on to go, how much of this actually matters and what is clinically relevant, because not everybody is obsessive and neurotic enough to care about everything that's wrong with them.
Yep.
Like, you have to match this up with patient goals. That person could not give 2 shakes about their right shoulder because it doesn't hurt.
Right.
But if you don't let them, of course, you need to let them know, hey, this showed up on the scan. It could become a problem in the future. And if the person's like, absolutely, let's knock this out. Like, I don't want this to become a problem. Like, I may be about to move across the country and then I lose your expertise. Or I'm about ready to get back into the gym and start hitting it hard and I don't want issues.
Overhead.
Yes. But you have to really think, like, okay, that's almost a trap of collecting too much data, almost like Dr. Andy Galpin and Brian McKenzie talked about in the book Unplugged.
Yeah.
We have this quantified self movement where you can calculate and collect everything. You got people like Ben Greenfield and Tim Ferriss that are wearing continuous glucose monitors and like testing and tracking every single thing, and like, I'm surprised they can even walk around. They get blood work done so much. They're like probably anemic. But we have to, as clinicians, like, use the technology, but not let it take over our critical thinking skills.
Exactly.
Like, we can't be like the modern day car mechanic where they just plug the computer in without taking the car for a drive and listening to the weird noise that the person's reporting it is making. We can't just go, okay, this is the error code, this may be the problem, because the error code may be, oh, the O2 sensor's out.
Yeah.
But why'd the O2 sensor
Caused
go
by
out?
something else, right?
So you still have to be a critical thinker, because our field is an art.
Mm-hmm.
And if you don't treat it as such, you will burn out, you will get bored, and you will look for something else. But if you treat it as a craft and an art, you will never get bored. You will always be humbled by how much we don't know or how much you disagree with what we thought 5 years ago. So it's pretty cool.
Yeah, and I really like that you're talking about the over information. So what the system actually does, it'll actually track the whole body, and it'll take ranges of motions of all joints, and you can literally pull out every second of a movement and see exactly where the body is in space in 3 dimensions. But do you want to do that? And that's my point, is like you're saying, you don't want over information. So all of that is condensed into, like, hey, here's the issue for this functional movement screen, and it gives you your top 3 and top 3, which is great for a practitioner, because now I'm looking at top 3, because I promise you that anyone goes through a functional movement screen, they don't only have 6 dysfunctions. They're going to have a ton of dysfunction through their body, but you got to find the ones that show up the most and all that, which can be fairly hard whenever you go through an FMS or an SFMA. You try to go through all that because you got to write everything down and try to take all that data and try to figure out, okay, what's causing what is this and this, and then you can get lost, like you said, you can get lost in the data. So if you're starting to look at it and you don't have something that's maybe like these are the top and these are the top, I'm looking at like, dang, okay, maybe it's something that's going on with this, like a hamstring. Maybe I'm looking at like a psoas. It could be anything. It could be pelvic floor. It could be anything going through. And I think that's something that's good to talk about too, is getting people to be more focused and really, like you said, treat it like an art. Because what we're doing is we need to practice. We need to continue to be artists with what we're doing, and then to get better at movement. We need to all be better at movement because, I mean, we know people are going to get hurt, sick, whatever, just from not moving, lack of movement. Mm-hmm. But when they're moving, they need to be doing it right.
Yeah, the whole Gray Cook thing. First move well, then move often.
Yep.
And you look at people who break a hip, like the hip fracture doesn't kill them. Their lack of movement or them being in a hospital and getting some crazy nosocomial pneumonia kills them.
Yeah.
Like our lymphatics thrive on movement. Like when people are sick, I tell them, unless it's like allergy driven with cedar out, I'm like, you got to go for a walk. Like you got to get those lymphatics going because otherwise the body thrives on movement.
I'm about to turn this back to NCAA really quick. Okay,
Yeah.
I can't remember if it was North Carolina or it was, I should, because it's a huge player, big team, but they're talking about something going on in his foot and in his ankle, and they said, well, we could have put him in a walking cast, or we could have put him in a movement, like something that's going to move more, but they said it was going to heal faster if it was casted. And I immediately kind of stopped because everything that I've worked with, when I do ankle sprains, and I don't know if it was an ankle sprain, I'm not saying I know what's going on here.
Yeah.
But because I turned it on, it was a guy in a cast, and they said it's going to heal faster in a cast, and that's rare for me unless it's a bone. If it's a bone break, then I'm like, yeah. Then I mean, you don't want to keep adding weight to that. But if it's an ankle or if it's anything in the tissue, that tissue needs to move so it can pump. It's going to get nutrients to it. It's going to pump bad stuff out. I mean, you've got to keep the movement in there. And when I saw that, I was like, well, it might push them another week or two.
Yeah, if you immobilize something for 3 days, the muscles start to atrophy. You get proprioceptive deficits. And yes, it may heal faster in giant quotations, but how much rehab are you going to do on the back end? Or can you concurrently rehab it and use a lot of these are over conservative litigation driven solutions because people don't want to get sued, because a lot of these big players, they're going to go out and they're going to sign multi-million-dollar deals.
Oh, yeah.
And the doctor who maybe manages that with a little bit more freedom rather than this like overly conservative approach could get blamed for any chronic drag out. But if the person plays it the absolute safest, like, oh, I'm never going to drive to work because I could get hit by a car.
Right.
Like, well, enjoy your time at home.
Yeah.
But we can say, hey, wear your seatbelt, look both ways, and don't go over the speed limit and go to work.
I mean, you can really enjoy your time at home, though. You have a huge dog here. Nissan is just the sweetest guy, too. I walk in, he goes, no, you're not afraid of dogs, are you? And I was like, nah, I'm not afraid of a dog. He opens the door, and the dog's at my chest, and I'm about 6'4", so it was just like, oh my gosh, that's the biggest dog I've ever seen.
He would love it if I never went to work, but then we wouldn't be able to afford all the expensive food and toys and vet bills that he enjoys.
From the big dog, yeah. Exactly. No, that's cool. I mean, like I said, I wasn't saying I know what's going on with that situation, but with a cast and anything like that, you've got to be wary. And then my thought process is there's a reverse to that. Yes, you're being safe, and yes, you're being conscious, and yes, you're doing that for the athlete right now. But if you're losing proprioception and you're getting some atrophy and you're getting like a movement dysfunction, you're going to have, I mean, just talk about the basics like tightness, and it's going to be weaker, right? Those are not good words to use, but I mean, that's what it is. And if they come out of that cast and they go play in the NCAA tournament at a high level as best as they can, are they going to be able to perform? Will that cause injury? Will that cause something else?
Yeah.
And that's my thing, is like, okay, that foot might not get hurt, but what happens to their hip, their back, the shoulder? Anything comes out that way because they have a major movement compensation now.
Yeah.
So that's what I think about when I see that.
And I've used immobilization judiciously to where we may have a senior volleyball player that has needs to get exposure in the last bit of the season, and she may have early stages of a medial tibial stress syndrome or maybe a borderline stress reaction to where you'd have to do thousands of dollars worth of imaging to see it, but she's got edema and pain pushing on the tibia. I've put people like that in a boot when they're not playing, and then they just take it off and play. I know that UT does that for a lot of the posterior tibial tendinopathies because these kids are walking all over campus loading that tendon. But that's a totally different scenario than your person in the general population who is just wanting to go and walk to the mailbox and get out of bed and not wake up with pain. That's a completely different set of principles, just because that's just purely load management to get through the season.
Then that's not specifically like, oh, I have a major injury that happened too. There's no MOI or anything like that. That's just more of like, okay, I'm gonna that's management. That's what
because a lot of these big programs, like with this volleyball player, like I sent her over to Daniel Martinez at Trinity, who does a ton of video analysis, force plate analysis, jumping mechanics. This girl was jumping like a flamingo and landing on that one leg, and she had a previous history of a high ankle sprain on that side. So it's just the perfect storm. But we weren't going to try and correct that mid-season just because kids in 4 AP classes in the middle of the season, it's not going to be in the cards.
Yeah.
But after the season, you have to correct that. Just like all those UT athletes, they're going to figure out why that tendinopathy arose with some sort of system, and then fix it in the off season. And with your new venture, I think that's really cool because how many courses do you go to from an SFMA or FMS or TPI or Racket Fit to where you're learning these screens and you compare them to the other people in the class and they're all over the board.
Yeah, 0 to 3 could be anything.
Like it's like one of them will give them a 1 and the other one will give them a 3, and like you don't have this reliability and consistency. Whereas if you're using technology, that takes a lot of the user human error out of it.
That's my biggest key too. Is like we all look at stuff differently anyway. So whenever we're looking at the human brain is gonna make you look for certain things anyway when you're looking at movement. You're going to notice things, something more than I'm going to notice something. I'll notice something more than you're going to notice something because it's something that we've seen more. And we try to stay away from that as best as we can, but occasionally it happens, and you have that. So I had a basketball player up in Medicine Hat in Alberta, Canada, and Dr. Kamo and I were working with her, and she just kept having this like you're saying, the posterior tibialis was just getting lit up on her. It was the same thing. So all I did was kind of take her through a little bit of a movement screen, and I was like, "Oh, look at that! You have a lack of mobility in this ankle. You have a little bit of stability issue in this hip." So we did we just added that little bit of rehab in, stripped her posterior tib out a little bit, and got into that calf and got into the soleus, and then she started to walk better, and she was like, "Oh, everything's starting to feel better." And it was when I first touched that leg, that thing would not move. Like it was solid.
Yeah.
And then after a couple weeks later, I could come in. I could actually move her gastroc and move everything through, which was nice. That was good to see.
That's awesome. And the big thing, and I want to mention it before I forget, you're not going to get big toe range of motion gains overnight. Like this is not a joint that you're going to get a cavitation, you're going to adjust it, and it's going to move 20 degrees more. I use the analogy of it's like breaking in a baseball mitt. Like it's daily progress and movement. Just like when you're breaking in a baseball glove, you got to go play catch with it every day to break it in so that it moves better. The same thing goes for the biggest metatarsal and a huge joint with 2 sesamoid bones under it. It's going to take some daily mobility stuff to get that moving, because you have to have the requisite range of motion before we can correct your gait mechanics and your movement. If you don't have it, it's like asking me to dunk a basketball. Like I don't have the hops to do it. You can tell me until you're blue in the face, but I can't do it unless you give me a trampoline.
Oh, I thought you knew. I listened to an episode where you had a hops episode, so I thought you would be dunking by now.
No, I don't take my own medicine.
Okay.
But you got to get people just expecting that, hey, we're going to get 1% more mobility every day. If we try and bulldoze a mountain in one swipe, it's not going to turn out well. And then until that happens, though, I tend to put people in more of like a rocker bottom shoe, like a Hoka.
Yep.
They have a meta rocker, and that will substitute for a lack of actual big toe extension. It will help them get that 4-foot rocker and get them that toe off. And I've had a lot of people to where they've had 4 bunion surgeries. There's a very limited amount that I'm able to do,
Right.
but they do really well in a rocker bottom shoe, and then in their boots or their dress shoes, we'll put a Morton insert in there, and that will help them it basically puts the big toe on a lower level than the rest of the foot, so it's kind of cut out where the big toe to the metatarsal phalangeal joint. And it just allows them to kind of drop down into the shoe a little bit more and get a little bit of false extension.
Yeah.
Because a lot of times you just need those temporary interventions to get it calmed down to where it's not as inflamed, so people can get their rehab done, and they're not going to have to live in Hokas the rest of their life. But
Nissan just joined us again.
Yes,
sorry. the big dog.
Yes, he's looking at us like he's at the zoo.
I don't think that door can hold that dog. He can come right through that door. If he wanted to join this podcast, he'd be in here.
He just has not quite mustered the brain power that door pulls in rather than pushes out. Otherwise, he would not be contained.
Or he's really nice and not trying to break down that glass.
I just think he's dumb.
Okay. We can go with that route too.
Yeah.
No, but I mean, we keep coming back to rehab. I mean, rehab's an important thing. I preach this a lot because my analogy I use for patients is that rehab is your save button on a Microsoft Word. You're not going to write a 5 to 10 page essay and then not hit save at the end. Then you're not going to do all this work with me in the clinic and then not hit save. Like, you don't want to go through it. My myofascial does not feel good. I promise you're not going to like it. I know yours doesn't feel good. I've had it done. So that's what I'm saying, though, is like patients are going to keep having to get more and more work done, and it's going to get more difficult over time because your body's going to start to adapt. And then you're going to have huge gains, but if you don't rehab it, it's going to get harder to fix.
Yeah. And like I tell people, all I'm doing with my hands is I'm shaking the Etch-a-Sketch.
Exactly.
So that your rehab works better. And if somebody isn't my age or older, they just look at me like with eyes glazed over. I'm like, just Google it later. And like, yeah, they're like, Etch a what?
What is it? Oh, it just got lost. I was gonna say that app where you used to draw with the friends.
Yeah, the draw something.
Draw something.
Yeah.
That's what they know. We got to switch to draw something.
Yes.
Something like that. So we got into a lot today. I think that was really good. Actually, we're gonna do this again. I say that quite a bit because the guests that I try to bring onto the show, onto the podcast, I want them to be people that we want on again because you're just a wealth of knowledge. You worked with tons of athletes, tons of people, not just athletes. You've worked with regular people, everything, and you've gotten to see. That's why I wanted you to talk about great toe extension because you're going to be able to talk about it with the athlete that has issues, and then the person that's wearing stilettos on the weekend that's causing an issue, and it's from work. So I think that was really, really big, and thanks for joining us today. That was great.
You bet, man. It was fun. I'm more than happy to get together and you can pet Nissan and we'll drink coffee and record and nerd out.
I was gonna let Nissan sit on my lap. I might just sit on his back. I can ride that dog like it's a horse.
Yep.
That's awesome. Well, thanks, Doc. I appreciate you joining us.
You bet, man. Cool.
Yeah, that was great. Right at 30 minutes.